My job is to talk about five abstracts which are largely on HER2 positive tumors. And I think the essence of these five abstracts is there is a study which talked about if could judge a response earlier in a neoadjuvant setting. All these five data set are a neoadjuvant setting by doing a PET-CT scan. There is an updated analysis called Sherlock Study on combination of trastuzumab and lapatinib. The Catalin study, which talked about role of neoadjuvant Kadcyla or TDM1, and an updated analysis of subgroup factors. There is a cardiac safety study called Burney study on combination of pertuzumab and trastuzumab. And the last one is actually quite interesting, potential role of a non-chemotherapy regimen. The first is the Tbcr C026 study. This was a phase 2 study from Johns Hopkins, and it wanted to analyze the fact that can we predict that an individual would have a PET-CR if we were to do a early PET-CT scan. So that's what the study was designed at. The idea was to give them treatment with trastuzumab and pertuzumab alone for 12 weeks. So that's also one of the chemotherapy-free regimen study, although we will be talking about that in a different study set. And they did a cycle 1 day 15 SUV values, which is also called an SUL because they took standardized uptake lean body mass values. So they will be called SUL values after 15 days. So that's pretty early, but that's how they valued both the absolute value of the SUL at day 15 and the reduction from the baseline. In the previous studies like Neo-Alto study with lapatinib, there has been some evidence that in a HER2 positive tumor, it may be possible to demonstrate decreased SUV values and predict a PET-CR, and that's how this Johns Hopkins group went in for this combination. Schema is complicated. Patient had pertuzumab and trastuzumab. If they had a clinical CR, they went for surgery. If no clinical CR, they can still go for surgery, but the biopsy is negative, they can go for surgery. If the biopsy is positive, then they can have chemotherapy. It's a complex protocol, but one could see, largely speaking, what the data said, with the number of patients being 83, the overall PET-CR rate was 22%, and you could see that the patient who had PET-CR, they had lesser cycle 1 day 15 SUL values. And if you look at the reduction of SUV values, percentage reduction in SUL max, then you can see that PET-CR patients behave in a different fashion, and it is evident here with the mean SUL max here, which is different in the two group, both the PET-CR group and the non-PET-CR group. And if you look at 40% reduction, then 83% of patients in PET-CR group, whereas only 52% of patients. So it seems that one could potentially predict in future. Yes, prediction of response is very welcome. There is a possibility based on this study that a PET SUL values on day 15 could be used, and they are going to raise a phase 3 study for validation. More interestingly, there was a high negative predictive value which suggested that a negative result would possibly suggest that you need to move to chemotherapy or a different chemotherapy. One should realize that not all good responders had PET-CR, and not all FDG responder had a PET-CR. So it's not like a 100% thing. Early days yet, but it is early days yet, but yes, it is quite exciting. Second study is a combination study, the Sherlock study, which was analyzed before and has been updated. It had three arms. Arm A of chemotherapy plus trastuzumab, arm B was chemotherapy plus lapatinib, and arm C was chemotherapy plus trastuzumab and lapatinib. This is an updated 5-year analysis, and one could see that the light greenish bluish line is the one with the combination of chemotherapy, trastuzumab and lapatinib that does better, and then the second arm is lapatinib and third arm is the trastuzumab, which is slightly odd because the new Alto and the Alto trial, the lapatinib trial did not show any significant benefit, so this is slightly different. And also in a metastatic setting, trastuzumab has been able to compete with lapatinib quite well. So I don't think we would have any major take from that. The good point was they also analyzed the tumor by PAM50, and they could identify that the luminal A, the HER2 positive on gene expression, and a luminal B would do good and a basal would do bad. But I think there is no major learning take from us. One would have been extremely happy if we could have utilized lapatinib plus trastuzumab vis-a-vis trastuzumab plus pertuzumab, because that will make our treatment financially much more viable and easier. But I don't think this study has any practice-changing impact at this point of time. One of the study was to utilize TDM1 in place of chemotherapy regimen. So Captain, which was presented before, had anthracycline regimen and a standard chemotherapy of trastuzumab, pertuzumab, and taxane, and in a way non-chemotherapy partner of TDM1 plus pertuzumab. But we all know that TDM1 is actually containing chemotherapy, and we know that the Caitlin trial was negative, leaving the standard chemotherapy plus trastuzumab perjeta. Now, the same group which did Kathleen publication, they tried to analyze various subgroup analysis, degree of HER2 positivity on IHC, gene ratio, copy number, RNA signature, degree of IHC expression, PI3 kinase mutation, and PTEN. And unfortunately, consistent with primary study results, a replacement of trastuzumab and paclitaxel with Kadcyla, which itself contained a microtubule inhibitor, did not show any additional benefit in any of the subgroups. So therefore, Caitlin trial remains in a way failure, and the current standard of taxanes with trastuzumab and Perjeta remains the standard of care. So no new change from this. The NICE trial was a cardiac safety trial, and there is now a final 5-year analysis. Although they did some survival analysis, but you have to realize that the basic angle was safety point. It had anthracycline of two different kind, pertuzumab plus trastuzumab, and a two different taxane um, uh, in a standard neoadjuvant chemotherapy protocol. And they wanted to see the class 3, class 4 congestive heart failures, and also echo guided left ventricular ejection failure of more than 10 points from baseline. If you look at class 3, class 4 congestive heart failure, the cumulative incidences are not very high, 1.5 and 1, which is more or less similar in both the group, but you could expect that kind of congestive heart failure. And a 10-point decrease in LVF did happen in a large number of patients, 13.6% and 12.1%. In fact, some of the patients had a drop in LVF 42 days after the treatment was stopped. There's a standard way of analyzing echo till the treatment is there, and we do not normally do, at least I don't normally do an echo after the treatment with trastuzumabs or the other mabs are done. But it seems that in this trial, continued follow-up resulted in more patients having low ejection fraction. So although the class 3, class 4 CHF is not common and they have been reported as very low toxicity, but I think I would like to know what was the long-term follow-up of these 13% or 12% of patients who had decreased 10% LVF, because one would anticipate that there would be a decreasing ejection fraction or stabilization, or they might have a higher cardiac event rates, particularly if they're diabetic, hypertensive, and elderly. And these numbers, although reported as minor, I think it does represent a significant chunk of population, because these drugs are being so commonly used now. And one would like to know that. Also, one would like to know what would have happened if they would have been treated with beta blocker and ACE inhibitor, as there's some data to support that. The last study is the WSG ADAPT study on HER2 negative and HER2 positive study. It is a study which is aimed at de-escalating the treatment by trying to have a chemotherapy-free regimen. The patients got trastuzumab plus Perjeta, and the group B got, or the arm B got trastuzumab, pertuzumab, and paclitaxel, and the endpoint for pathological CR and other survival data set. So an attempt was made to have a non-chemotherapy protocol. So you could see that when you give taxane to combo HER2 drug, then you can achieve a PAT-CR in a higher number of population compared to non-chemotherapy. But there's 30% population which can achieve a PAT-CR just with with the dual hernia combo. And you could see in both arm, and particularly when you have had chemo, many of the physicians opted not to even give them any extra chemotherapy. So these patients, arm A, actually had a non-chemotherapy regimen, trastuzumab and pertuzumab, PAT-CR, and many of the physicians were comfortable to continue that. So that's like a non-chemo regimen. Now, next three data set: invasive disease-free survival, distant disease-free survival, and overall survival. Going back, though look different because the difference, for example, in IDFS is around 11%, but statistically not significant. Seems like that the chemotherapy-based regimen does shade better, but is not very clinically significant or statistically significant. So it seems that this idea of trying to achieve a PAT-CR with a combination hernia, and if you're not able to achieve PAT-CR, then moving on to standard chemotherapy can lead to about 25 to 30% of patients who do not actually require chemotherapy, and that's very exciting. This study needs to be taken further, and similar concept studies like COMPASS and Decrescendo are ongoing. So this represents another attempt at de-escalation like Dana-Faber protocol when we have only weekly paclitaxel or 3 to 6 monthly short duration trastuzumab. Here we are de-escalating like we are de-escalating radiation and surgery. We are de-escalating and trying to achieve a chemotherapy-free regimen. Well, that is not going to be for all, but it seems that selected patient eventually could be selected. For example, the first study talked about a PET-CT to find out who were going to have a PAT-CR, and if we can identify and achieve PAT, it's a possibility in future that a chemotherapy-free regimen may be possible in super responders, super achievers. Similar DDFS and OS, it is a very exciting study. Thank you.